Right. Good afternoon, councillors. At the minute, I only have a small picture of myself. I can't see anybody else. So, Chris, if...
John Richard Dodd, there seems to be a fault. You'll have to rely on someone to tell you who's got a hand up.
Yeah, thanks, Richard.
Or electronic hands.
Yeah. I don't know, Chris, have we got Heather there as well as yourself?
No, it's just me today, Chair, so I'll keep an eye out, though.
Great, thank you. I can see people when they start to speak. Right, good afternoon, councillors and ladies and gentlemen. Welcome to the Health and Wellbeing Overview and Scrutiny Committee on the 2nd of February. Could all councillors, because I know we've had problems with feedback over the last couple of meetings, if you could make sure your mics are muted, and if you can electronically raise your hand, and hopefully Chris will see you. I've got no pictures apart from a small one of myself. If we can get on to the agenda proper. Apologies for absence, please, Chris.
Yeah, I've received apologies from Councillor Jones, Chair.
Great. Any other apologies from the floor? I don't have any. Great. Minutes should have been next, but they're not on the agenda. They will be here for the next meeting. And Chris, if members want to see them before then, can we send them out?
Yeah. The minutes from the last meeting have been finalised. So they'll be coming to. They weren't ready in time for the agenda, so they'll be coming to the March meeting. But if members want to see them before then, just drop me an email and I'll circulate them. Great,
thanks for that, Chris. The closures of members' interest, do we have any? Can't see any hands up, so. The forward plan, item A on your agendas. I think this is just really for noting. We do have a note on that about the budget where all members are invited. Chris, did you want to say a few words on that?
Yeah, so the forward plan is there for members to note. The thing that's on there is the budget for 21-22. That's going to corporate services scrutiny on Monday, the 8th of Feb. All members are invited. If members are wanting to physically join the meeting, if they can let either the chair, Councillor Bourne, or myself know, we'll make sure you're included. And if there's any written questions members want to submit, if they could submit them to either myself or Sean Nicholson by the end of Wednesday.
Thanks for that, Chris. Have any members got any notes to raise on the forward plan? See anybody? Thanks. Item B on the agenda. We have two. We have the minutes of the Health and Wellbeing Board held on the 12th of November and the 10th of December. Councillor Dodds was in the chair. I think this is just to note the reports. And any comments from any councillors? No, sorry for the delay on this. As I say, I can't see councillors. Right, there was a little bit of confusion on which part would come next. Item C. Chris, who's available and which one do you want to take first? Dr. Graham Sayers or?
I think we agreed that Northumbria Healthcare were going to present theirs first.
Great. And Jim Mackey, have we got him available?
Yeah, I'm here, John. I'll just try and load up the slides if you give us a second.
That's no problem.
Can you see those slides yet?
I can only just see yourself.
No? Okay, sorry, I'll just get some help. Just a second. Are they visible now?
No.
I can see it, Jim.
Yes, it is there now. Can everybody see that? Yeah, I've got that up.
Okay, thanks very much. So I'll just talk through, it's a fairly standard slide deck that we've used for other external partners and our governors and board, etc. So there's quite a lot of data. It's very fluid, the whole COVID situation, and quite complicated. So please feel free to just ask whatever anybody wants. If anyone's got anything on their mind, just ask away, and if it's terribly technical and complicated, Alistair will help me out. So I'm going to give a bit of an update on the key numbers and metrics. I'll explain where we are now. Just as we speak, our regional daily call is happening, where every health organisation across the North East meets every day at 1 o'clock to just take stock, and that's where we've been doing all of the daily juggling to help each other out, especially colleagues in Cumbria and in Tees and Hartlepool, where most of the pressure has been felt. So we'll talk through a bit of that as we go through, and then there'll be time at the end, as was said, to answer questions. This first infographic shows how many COVID positive tests we have on a daily basis. So you'll see 100 tests conducted in this particular day on the 21st of January, 17 positives. Just for context, our highest ever day happened 2 or 3 days after this, which was, I think, about 33 to 35 patients. In the autumn, before the second wave happened, we would be having maybe 1, 2, 3 positive tests a day. So you can see it really ramped up around Christmas and just after Christmas. And there you can see as that steadily progressed from almost nothing in September through to October, and then really picked up around just after Christmas, as probably we'd all expected after a relaxation of the rules and the new variant. This is a busy and complicated infographic that I'm showing now, and this basically is what we use to track bed occupancy within the organisation. So if you look at the box in the top left hand of the screen, trust total 80% occupancy, which in headline terms is very healthy. On this particular day, 21st of January, we had 157 empty beds and 173 COVID positive patients at that time. So just around 800 beds, 173 COVID positive inpatients. It increased after this date up to about, I think, 187 at its peak, which is the highest we've had so far since COVID began. Just below that top box, you'll see our critical care capacity, which is the thing that gets most of the media attention. Slightly complicated from our perspective, which I'll explain in a moment, but you'll see on this particular day we had no available critical care beds, but this is very fluid. You can have no beds now at 1 o'clock, 3 or 4 beds available at tea time, and I mentioned earlier the juggling with colleagues around the region. We've been doing that on a daily basis with our critical care network, which has very effectively helped us distribute load across the region and allow Newcastle to take some patients from the south of England and Birmingham. Colleagues here have tried to represent on this chart just how the shape of the curve is different from the first round, which is the light blue line, then the orange and then a multicoloured line, which is the second wave, and then the purple line on top of that, which is the third wave. If you remember, it looks like London and the southeast actually only had 2 waves, so they missed the middle one out. It's hard to tell whether we're actually in a third wave or just a continuation of the second one. But in reality, we've had three peaks effectively, each one getting progressively more difficult. So the first one was the easiest, oddly. In spite of us knowing less about the disease, we had very, very significant bed capacity available because everything else was cancelled. Second time was a little bit more tricky, but we coped very well. Again, fairly comfortable from a bed capacity perspective, other than a few days with critical care. And I think it's fair to say this round has been more challenging and more stressful for our staff, with fatigue especially being a major issue of concern for us. You can see there again at the time of doing the slides, we'd maxed at 174 COVID positive inpatients. On the left of the chart there, you can see in the April peak, we got just over 140. It's not absolutely certain 140 was right because there's very limited testing at the time. So it's very likely we actually had maybe 180, 190 or so patients around that time. But you see the big peak again into early November, just before Christmas. It eased slightly over Christmas and then took off again. And then again, very sadly, focus on mortality and deaths. I'll give you some more data on this shortly. There were 2 months in the summer, July and August, where we had no COVID deaths, and they've obviously picked up again during November and December. And January is a heavy month from a COVID volume perspective, but also from a death perspective. Very sadly, yesterday we lost our first member of staff to COVID. So I think until that point we were the last organisation in the NHS that hadn't lost a member of staff, as far as we're aware, and we're really hoping to get through this without that happening, but sadly that's not been the case. So the organisation is in a degree of shock today as a result of that. This is again an infographic we've been using at the beginning to just track headline volumes and mortality. So you can see there, and this is hard to get your head around really. We've had just short of 100,000 admissions since lockdown began on the 18th of March last year. Of those, 2,400 patients were COVID positive admissions. And at the time of writing, we'd had 512 patients die, sadly, of COVID in that period. So it's obviously a very, very tragic and significant impact on communities, the people involved and our staff. But we have been very much open for other normal business as well, with around 100,000 other admissions, and on top of that outpatient volume and ED attendance volume, etc., throughout to maintain other services. Comparing mortality is very, very difficult because of the way different systems work. In some systems, more people have died at home or in nursing homes than in hospital. Other systems, it's the other way around. And then raw headline hospital mortality is very hard to get a hold of and very difficult to compare. You'll see from these charts that we've had roughly 21% of our COVID positive inpatients have succumbed to the disease and sadly died. That's at the top end, strong end of performance, but I would say just be very cautious with that because the need to look at the system in the round, and very importantly, long-term excess deaths, which is helpfully getting some publicity now in the media and some more intelligent commentary compared to that earlier in the year. I mentioned earlier on the issue with our critical care data and being full on a particular day and how that reflects with others. And we have the advantage in Northumbria of a respiratory support unit on our respiratory ward, which is Ward 12 in NSEC. And this is where most of the non-mechanical ventilation happens. So CPAP, which I'm sure you've heard of, and non-invasive ventilation largely happens here. And this, just flip back and forwards, you see that 135 patients have been in our critical care unit with COVID since the 18th of March, but 217 patients have been through Ward 12 at NSEC, reflecting that very significant additional capacity, which we do think has been able to allow us to withstand the shock of this much more effectively than other similar organisations, to the point where since the week before Christmas we've been taking patients from Cumbria, Teesside, south of the river into critical care and some into our respiratory support unit. And that's also helped decompress Newcastle occasionally so that they can be on take for more recently Birmingham, but before that Surrey, Sussex, South Coast sort of areas on a daily basis. You can see there how bed occupancy fluctuates. Again, we've been relatively comfortable from a headline occupancy perspective throughout COVID. Most of the pressure is felt on the Cramlington site, obviously, so our occupancy there is tighter than elsewhere. But overall, only a few days where we've really struggled from a bed capacity point of view. And you can see here just again a short snapshot that indicates the impact of better treatments and a better understanding of the disease after the first wave, which is reflected in very significant improvement in mortality. And what we are finding now, every week it changes as new treatments are tried and come on stream, is that patients have a very, very significant increased chance of survival now, but also stay with us very much longer than we would have expected in the beginning. So it's positive in terms of survival, but in terms of health capacity, obviously it does stretch us a little bit further. You'll have, I'm sure, seen in the media the North East rightly getting some recognition for the fantastic delivery of the vaccine programme. So we were late getting our supply in the North East, especially in Northumberland and North Tyneside. I think our primary care colleagues have done an incredible job, and frankly, in partnership with ourselves and with local authorities, etc., would have probably had the whole population, adult population, vaccinated very, very, very quickly.
Chair,
if supply had been. Sorry?
Can I come in there, Chair?
Yeah, sure.
It's just about the vaccines. How the doctors up here are doing really, really well, but it's the shortage of the vaccines, so they've got to wait another 3 days. One medical centre's run out at 12:30 today and got to wait till Friday. So it's, you know, and the other thing on that is the letter that's been sent by the NHS asking people that they want to go up to the Centre of Life for the vaccines. Now, to me, that's wrong, because we're told not to travel unless we really need to. So why do that? Why can't they just wait for the doctors to get in touch with them, because they're doing a really good job on it?
Yeah, I think they're very good points, and our preference would be that primary care, which is proven itself very effective at vaccination, would have been the main delivery method for all of this. It's been controlled through a very centrally controlled process in London under the command and control system that we're in as a major incident, and supply is pushed out accordingly to their direction centrally, which does mean that we have periods of reduced supply, and there will be a feature of the next few months of more outlets like the Centre for Life, drive-through kind of facilities, etc., to get the volume up. We've tried very hard to influence that, and it's just not been possible, sadly, and we are now going through a process of allowing the South to catch up a little bit, because the distribution was lower to them at the beginning, I think largely to reflect the pressure in London and the Southeast over the Christmas period. But we would all agree it's incredibly frustrating. We'd all really hope that we could go hell for leather and get this thing done. I think, to be fair as well, though, 3 months ago, none of us thought we'd have a vaccine that was viable and effective as this. So it is very early days to have any supply. Would really expect it over the next 2 months or so to really ramp up. But I wouldn't let that distract anybody from the fantastic job.
I would just say,
can we get through the whole of the presentation and then bring your questions in at the end?
I thought you said we could ask as we went along. Sorry.
Just really to get things started. No problem, Kath. If we can just get through the presentation, then we can go back and ask if that's okay. Yeah. Thanks, Jim.
Okay, so just moving on briefly, we are in a much stronger position now from a community infection perspective. I'm sure you've heard that from Liz Morgan and other colleagues. Our community rates never really got to the levels of London, the South East, nor indeed Cumbria, who had the new variant very much earlier than we did. So we are back to, it looks like, sort of October, November levels of community infection. It hasn't yet fully translated into a significant reduction in hospital admissions. So we are still getting around 10 or so admissions per day, more on a heavy day, and it hasn't really fallen off in the way that it has in the previous few waves. So we are hoping that will start to kick in the next week or so. We've been very stable at about 170 COVID positive inpatients, which is where we're at today, and have been there probably for about a week now. We're on 180 odd for about a week before that. So it does feel like this will be a bit of a long tail out. There are some early signs that colleagues in public health are indicating that the vaccine is visibly having an impact in certain parts of the country. But again, I would think this is a little bit early to bank on. And I would just really emphasise the way colleagues across the health service and with local authority partners across our system, but also the broader North East, has been absolutely phenomenal with incredible collaboration. We're just re-emphasising all the time about sticking to the basics as well. So this variant is very much harder to contain than the previous one. We're all a bit sceptical about this around Christmas because of, the relaxation in London and the shopping on Oxford Street and all those sorts of things. But when you come into contact with this variant, it is very, very much easier to catch it. It doesn't look like it's any more virulent from our perspective in terms of impact on patients, but there's very much more around of it, and it's very much harder to control. And we have struggled with outbreaks in the hospital system, so we've got a very big focus on the basics and also trying to get people home as quickly as they can. I'll just do a quick update on other general things, and then quite happy to go back to the questions then as well. So just to emphasise, we've had pretty much a full range of services open throughout. We've had to cancel some elective planned surgery in the last few weeks. We did it for about a week in November into December to help free up staff for critical care capacity. This round it's been largely to help us support others in the region, and that'll get stood up hopefully next week. And our overall performance has been incredible throughout, with our ED performance being the best in the country for virtually every month of this year. Our elective performance is stronger than the national position in most providers pre-COVID. Our post-COVID performance is very much stronger, and you'll hear about things like cancer targets, etc. In a moment from other colleagues. Helpfully, many people have not walked into A&E than used to, so they are accessing service in a different way, and hopefully that'll continue. You can see there across the North East, stronger ED performance than the rest of the country and than in previous months. Just skip through this. And we've had a very, very big focus on staff and patient satisfaction, as always. Yeah, it's a big part of how Northumbria works, and continue to maintain very, very high levels of satisfaction in spite of the trauma and difficulty. We track our staff experience on a weekly basis through Northumbria Voice, and it's fair to say people are really flagging now. They're really tired. The impact of mortality is really taking its toll. The loss of a colleague yesterday will have a huge impact, etc. So we are focusing very much on supporting our staff through this difficult period. There'll have to be some form of period of recovery after this before we get on to restoring the full access and getting rid of backlogs, etc. And really interestingly, inpatient survey shows very, very strong performance again, some improvements year on year, where we're already pretty much the best in the country. So no real impact on patient experience as a result of COVID. We're managing to do other things here, so I'll just show you this to show how digital interactions have really taken up. But very importantly, you'll see a number on the bottom right there, 1.9 million fewer miles travelled, which was an aspiration before COVID kicked in, that we would stop having to move patients around for access to routine outpatients by using digital technologies and other means, and COVID has allowed us to accelerate that. So just short of 2 million miles fewer travelled there. And again, hopefully you'll have seen in the media and other sources recently, our PPE production hub in Seaton Delaval, which has produced huge volumes of gowns, and will expand into a broader supply chain for the NHS and beyond over the coming years. And this is just a slide that shows our early thinking of our strategy post-COVID, with a very, very big emphasis on trying to help our local community recover from COVID from a skills and employment point of view, use our spend and supply chain to try and bring more jobs back to the area, and a really big focus on long-term health with the community. So overall, just conscious of time, big thanks to everybody involved in the support we've had from partners, which has been incredible. The public have been very, very understanding as well. Now, so really would like to thank any members of the public watching. It's very tough. This has been a really hard year, and we are now starting to see some green shoots with the vaccine and other things that will give us hope for the future. But it's going to be it'll take a little bit of recovering from this. So very happy to go back and take questions now, Chair.
Very grateful for that, Jim. I have two councillors so far. I've got Councillor Nesbitt and Councillor Rigby. Councillor Nesbitt.
Just going back to the letter that's been sent from the NHS, I just think my husband's one of them that got it, but he had his vaccine the week before. Now, to me, we're trying to cut down the travel and that. So somebody going from Blythe, they want to get it done, so they're going to make that travel, and I just think it shouldn't be happening, especially when the doctors are doing a great job. But the report's very good. Well done. I think a lot of the staff's been absolutely amazing, absolutely brilliant. Thank you for that, Jim.
Thank you. And on your point about travelling, I think we'd all agree with that. My mother lives in Jarrow, and she her practice didn't have access to the vaccine, so she got a letter to go to the Centre for Life. We're all relieved that she got it, but our preference would have been she got looked after by her local practice, so would have just felt all safer and more convenient. But you can understand the complexity of dealing with this nationally with a new vaccine and just trying to get as much of it out as humanly possible. It's a very difficult process.
Totally agree.
So thanks for that, Kath. Councillor Rigby.
Yeah, thanks, Chair. Yes, Jim, I think everybody would want to give heartfelt congratulations to what's been going on and the way that the NHS has coped with it. So I'm not the only one. Thank you for everything that's being done. I'm not sure whether this question should be directed to you, so I apologise in advance. But we hear a lot about the South African variant, and we know that any virus can mutate exponentially. From what was being saying on the news, the South African variant is now beginning, sadly, to spread and come further north. Mm-hmm. So really, it was just a clarification of what we've heard that certain vaccines are better for the South African variant than others. So how is the decision being made as to who or what and where the vaccines gets distributed? Yeah.
So I'll have a go as an accountant, then Alistair, who's a doctor, will just correct everything that I've said. So it's all very, very centrally controlled. The whole thing, really, from a vaccine perspective, is very centrally controlled. And Public Health England and other colleagues are doing dozens and dozens of studies every day to just try and track effectiveness of the vaccine, mutations. We think there's about 150 live strains in the UK currently. This is what happens with vaccines, they just change and adapt all the time through history. So I've spent a lot of time listening and reading up on pandemics through history, over the last 10 months or so. It's usually part of the process that enables the virus to run out of steam. They become more infectious and then run out of people to infect. They usually do dilute over time as well. Or often dilute over time in terms of impact, etc. So I'm not too worried about the South African strain or the Brazilian strain. I think it's just part of what we've got to live with. And I think also, and I do take confidence from the way the studies are working and the fact that they are tracking every day whether the vaccines, each individual one is more effective or less effective on different strains. So I think, as we heard yesterday, we'll get to the point where some of the vaccines maybe need to be updated with boosters, and that'll be applied to make them more effective for the dominant strain at that time. Again, finally, before opening up to Alistair, this is probably a feature of our lives for the next few years, the foreseeable future, where we'll get used to being vaccinated for this in the way that we've been vaccinated for flu. And there will be long-term impact in the terms of how we practice, how we deliver healthcare, models of care, and how we're building safety mechanisms that understand that this thing's just it's not going to disappear. So Alistair, did I Do you want to help?
Yeah, I'd agree. I think what's worth understanding is what the vaccines do. So vaccines will do one of two things. They all appear to be reducing the admissions to hospital or risk of death. So even with the South African variant, we're seeing that the vaccines are still, on the figures that we've had, are very effective at reducing the need to be really ill or to come into hospital or die with it, which is great. The second thing vaccines can do is reduce transmission and spread. And whilst we haven't got everybody in the country vaccinated, there's a race between getting the country vaccinated and the South African variant, because that would spread. And so there is some evidence that it is more likely to spread if you've had a vaccine. So you may not be really ill, but you could spread it to other people. So the reason they're trying to stop the South African variant and some of the others in its tracks is not because it's worried that it's more fatal or anything. It's because it's more likely to spread. Yes. And because not all of our population are vaccinated yet, it then provides that risk. So I think that's probably why there is the concern about new variants. It's not that they are more risky, it's the fact that they may spread. And we know that there is still a big question mark over the degree to which a vaccine protects you from spread. And it looks like with the South African one, you may be more likely to be infected and therefore infectious, but not ill with it. So I think that's something that we need to keep a watching brief on. And from what I gather, that we probably will need at some point to look at updates on the vaccine, but that won't be so much because it's not working or that you're likely to come into hospital or be very ill. It's more likely to be around spreading it to try and control it for other people in the future. So it's all about getting herd immunity, not necessarily by us all being infected, but by us all being vaccinated to control it. So I hope that explains that.
Thanks for that, Alistair.
Can I just come back? Yeah, thank you, gentlemen. I mean, that's what I wanted to hear and what I knew, sort of thing. But I think it was important to ask because, like Jim, I've actually done some research on pandemics through history. And as you said, Alistair, they don't go away. We just learn how to actually deal with them better. And I think that's something that hopefully the message is getting out to people, that get your vaccine. Let's try and stop this, but it will not go away. And we know that from history that there are still plagues and whatever around the world. We just don't hear about them anymore because we can control them. Yeah. So thank you.
Thank you for that, Councillor. Councillor Dungworth, I'll have you next.
Thank you. Thanks for that report. I think throughout this, a lot of us have been really reassured, not just by our own trust, but by the Newcastle Hospitals Trust as well, which of course are used by a lot of our residents in terms of your responses. So, you know, thank you for that. What I wondered was the successes that we've had, how much of that do you think is around our special trust, really, that is a healthcare trust, that is not just a hospitals trust? I'm thinking particularly around freeing up hospital beds, a very clear understanding of discharge in the first phase, certainly in terms of elderly people. So I suppose the question I'm asking is, do you think it makes a difference having this partnership when we face crises like this?
Yeah, so I think the general strength of our services and relationships on the ground have really helped. So we haven't suffered the problems as we don't in a normal winter when others get stressed with not being able to get patients out of hospital, etc. That's never really been an issue here, and we do really, you know, value that and respect that. It's so I think it's a factor. There's still work going on in other parts of the country trying to help move patients out. So in Cumbria, for example, they had very, very large numbers of patients in hospital beds who should have been in another setting in social care or at home, and they couldn't get them out. And we would have really struggled without that. So we do really respect and value the relationships we've got and the way that people have worked together on the ground to deliver what was required.
Jim, could I just come in? I think one other thing that we've got to remember is that there is a lot of illness and suffering outside COVID. And I think what we've seen is some really good examples, for example, of the community teams supporting people dying at home. We've had more people dying at home over the last 12 months than previously, and we know a lot of people want to die at home, and one of the advantages of that is obviously if that's what they desire, then it's enabling for that individual, but also it then means that they're not coming into hospital at a time where probably coming in is not the right thing for them, and I wouldn't discount that aspect, and also what community have done in supporting care homes, which I think has been amazing, particularly in the first wave where care homes were disproportionately hit. It seems to be not as bad at the present time for care homes, but both of those are really valid points.
Can I just come back in there? I'm not sure if we're covering this later on, but I think we've managed to continue offering a lot of treatments that other hospital trusts across the country have stopped doing, which again, that whole issue of people carry on being ill and dying of other things. But I was listening to a radio programme last night and they were talking about how the figures have turned on their heads in terms of deaths at home. That we're still getting what we would expect seasonally, but people are not going to hospital. So you're right, that puts an additional strain on the community services, caring for and supporting people there. But again, you know, I have to say, in terms of continuing to provide surgery and cancer treatments for somebody who's got family in other areas of the country where that has not continued during this, I think we really shouldn't underestimate how valuable that is, that we've been able to continue doing that here.
Yeah, absolutely.
Excellent point, Susan. Excellent points. I can't see any other hands up for any more questions. Shout out if there's anybody. No, I don't think there is. Can I, on behalf of the committee, thank you and all the staff for all the unbelievable hard work that you're doing, have done over the last 12 months and continue to do. Obviously, our condolences to the member of staff and all other deaths, obviously, but just to really thank you for all the fantastic work that you're doing, and it is appreciated by not only this committee, but I know the residents of Northumberland appreciate all your endeavours as well. Thank you very much for the detailed report.
Thanks very much. Bye.
Thanks, Jim. Right, we have Dr. Graham Sayers, I believe, is with us.
Hello, everybody. Yes,
yeah.
Thank you.
Graham is clinical chair of CCG, and going to give a COVID update on his side of it. Carry on.
Okay, I think somebody somewhere has a slide set for me, please. Who's got them?
2 seconds. It is this.
Thank you. So, yeah, I'm Graham Sayers. I'm a GP in Alnwick, and I'm clinical chair of the CCG, and we've got some slides which will take us through some of the primary care issues that we've been dealing with, and some of it borders into a bit of what Jim's talked about, so we don't need to go into all of that in great detail second time around, but I will mention the care homes as well, I think. Next slide, please. So general practice capacity. So this slide is really about is your general practice working as it should be, and what capacity issues have there been? And the CCG has had a role in working closely with the surgeries, and we have this thing called a situation report twice a week, which allows practices to let us know how they're doing. And then if there are areas where there are difficulties being encountered, we have conversations about what we can do to support. Nationally, there was a general practice COVID capacity expansion fund announced, and that's allowed us to put some more resource to the practices that they can use to try and keep their services up and running. And there were some caveats with what that money was for. So it's about ensuring that you can employ more staff if you need to, that you support some of the national programmes such as the oxygen monitoring at home. And there were a number of other things. Long-term condition management would be one of them that practices are expected to try to achieve. The way that practices gain their income is a bit complicated, and if practices are expected to use their staff to support the vaccination programme, which we have been doing, obviously your practice nurses and the administrators that support them to look after long-term conditions are not going to be as available, and therefore we had to have ways of freeing up some of the capacity to allow them to do that. There's been national work come from the British Medical Association and the Royal College of GPs that tells us where we should be prioritising some of the long-term condition work. So you can imagine cancer screening might come high up on the list of things we would want to keep going with, such as cervical screening, but there might be some long-term conditions which have been very stable for a number of years, and it wouldn't be quite as important to get your annual checkup. So there's a list of priorities that we use to try to decide where we should focus our resources. And we also meet with the primary care network leads. Primary care networks are a relatively new organisation which club practices together into groupings, and we've got 6 in Northumberland now, and that's been a good way of keeping in touch with some of the local leaders around some of the neighbourhoods. Next slide, please. This graph makes your eyes go funny, and there's a lot of information on. I think this is a sheet that shows us what's been happening in primary care over recent weeks. And what I would do is take you to the list on the left-hand side under category. So these are the kinds of problems that practices might encounter. So staffing and absence levels, that might be because of people personally having coronavirus, but also obviously with shielding and things, people having to work from home, or if you've got children not in school, this has an impact on practices. And it's quite hit and miss which practices have had difficulties at certain times, so you couldn't go across the board. But most practices have continued to provide pretty high level of service so far. Patient demand, this has been an interesting one over the last few months. So under the first lockdown, patients actually stayed away, and there was a big worry that they were staying away too much, and there was hidden illness not getting dealt with appropriately because people were afraid to come forwards. We had a big surge over last summer, and then things to settle down in the autumn. This latest lockdown hasn't reduced the demand to the same degree, so people are still accessing us in the same way. Now that has caused some difficulties because on certain days when practices are busy trying to book people in for vaccines and use the phones for doing that, access has been more limited. So we do keep an eye on that. Practice service levels, so this is around, are you open for all routine things? Are you just open for emergencies today? So we keep an eye on that. Hot patient demand is around, do practices have facilities available to see patients who probably have COVID? We don't tend to see many patients who probably have COVID in primary care. Most people have tested at home, they know they've got it, they know they've got to isolate, and we can tend to manage them over the phone if they've got problems arising or they need to go to hospital because they're poorly. We tend to see more of the people who've had COVID who are no longer infectious but need help with other things. And then we've also been keeping an eye on the availability of PPE. That's actually, it was a big problem first time round. I've not heard of any shortages really of PPE in recent weeks. And then there's over an escalation level at the bottom. And maybe if you go down to the very bottom right-hand corner, so in the last week on this chart, which was in January, out of our 37 surgeries, 28 were normal business. 7 were having difficulties at that point, and that's been about that over the whole board, really. Next slide, please. Surge management. So this is really about how do we cope when we have one of these big surges going on, and Jim's covered this really in much of what he's discussed. We haven't talked about mental health too much, and about the 5th point down, our community mental health services have also been under pressure, so there has to have been quite a lot of work to look at how we manage that, and they've had staffing issues as well. So the CCG has been involved in making sure that we've got services going on there. Staff absence, something to bring your attention to as well. There has been some worry about people having to be off because of vaccination side effects. So if you get a temperature a day or two after you've had a vaccine and you're not sure if you've actually got COVID or it's to do with your vaccine, that may lead to some difficulties, although in practice has not been too much reported. All staff in primary care largely are being tested with lateral flow tests on a regular basis. Certainly anybody going into care homes is expected to be tested, and anybody providing vaccines from a vaccine site is expected to be testing themselves. And we've tried to encourage practices to take it on as well at other times, and it is available to all practices to use. We do have these daily system-wide surge calls, which Jim has already mentioned, so I won't go into that. Next slide, please. Care homes. There is the Joint Outbreak Control Group, and that gets involved when there's ever an outbreak in a care home, and that's proved really useful. We do have some significant outbreaks still going on in care homes, and for the ones that are affected, it can be tragic. We've recently had difficulties in some of them, and you know, if up to a third of your residents are affected in a significant way, it's an awful lot of work, and the care home staff also run into difficulties with that. I've just had a personal conversation with the care home manager today, and she's absolutely exhausted, both physically and psychologically, and I'm sure that's the case in nearly every care home at present. All of our residents in care homes have been offered vaccinations now, apart from those that may have recently had COVID, and we have to wait 4 weeks before we can offer it to them. So there'll still be some people who haven't had a vaccination, and we're just waiting for the right time frame. The infection prevention and control still just as important, especially with this new variant, that everybody is on their toes about not transmitting, not taking it into the care homes. Hopefully within the next week or two, all of our vaccinated care home residents will start to see some benefit from their vaccine, and some of these issues won't be quite so serious for them. Let's hope. The designated commission beds for discharge, that's worked really well. We've got some set up, and we've not had really great problems with bed blockages in the hospital for the lack of being able to get people safely into a more appropriate care home setting. And if we need to change that, we can. So that's been fairly fluid all the way through. Next slide, please. Long COVID, this is a devastating illness for those people that get it, and the more people who get COVID, the more of these cases we'll have. I've got patients who've been off work for 3 or 4 months, and it's not necessarily people who were admitted to hospital with COVID in the first place. It seems to be a bit random of how it picks people off, and some people just have extreme fatigue and episodes of breathlessness, but it can do many different things from COVID. We have got clinics set up in Northumberland that the GPs can refer to, and we have done work to highlight these to the GPs. So anybody who's struggling needs to know that they can come to us and get some help with that. The oximetry at home system is all about people who may be developing breathlessness, and we can now get pulse oximeters to them at home, and they can send us their readings twice a day, and we can monitor to see if things are deteriorating and take action if needs be. And that's been rolled out across the whole of Northumberland, so all practices should have options in that. And the CVW is the COVID virtual ward, and that's about people being allowed to get home but be monitored more closely at home. That at present, because we've been fortunate and haven't had quite the demand in other areas of the country, hasn't necessarily been activated yet, but it's there and it's being discussed if we need to. The next slide, please. This is all about system working, and I think Jim mentioned that, and you've discussed this already, but the response to this has to be discussed with everybody so that what's impacting on one person and how somebody changes doesn't affect anybody else, and I think we're pretty good at that in Northumberland. I draw your attention to the bit about the independent sector, which is just towards the bottom of the page. There are MRI scanners that weren't being used to their full capacity in private clinics, which can now be used. I think some of the Newcastle Hospital patients get treated and have their surgery in some of the private hospitals. So that's all about making the best use of the resources that are around. So that's just been ongoing. Next slide, please. And the next steps. So again, I don't know how many times collaboration is mentioned on here, really important. From a CCG perspective, making sure general practice keeps working, that people keep having access when they need it. And I think that idea about the long-term conditions, the longer things go on and get delayed, the more we have to just focus on who's got the priority on them, because you can only put certain things off for a certain amount of time before we run into problems. I haven't mentioned mental health on here, and I think I need to finish on that as well. More and more people's mental health is being affected, and we do have a focus on that, and it's not by any great omission of intent that I haven't mentioned it till now. Thank you. I think that's me done.
That's great. Thank you very much for that, Graham. A very detailed report. Councillors, are there any questions for Dr. Graham Sayers, please? Councillor Rigby and Councillor Bowman. Councillor Rigby first, please.
Thank you. Yes, Graham, I'm interested when you talk about the oximetry at home, and I've noticed that there is now seems to be a plethora of shops and whatever online selling these oximeters. Should people get their own, or my fear is that people will do just that, and then there'll be this you know, book diagnosis?
I think you're right. I think there is a danger in people getting them at home, in that if you haven't been shown how to use them and the significance of what you're checking for, there is a degree of error in that. And our local chest physician was a little bit wary. So it's almost as much as if you sit still and take lots of breaths for a while, your oxygen levels will look better than if you check it when you've just been walking around and feel breathless. So I think if it's done in a structured way with the right support, I think it can have a use. But I think if everybody started having them at home, we would probably end up needing to field too many queries from people who are actually well, and that would be the danger.
That was my fear. I'm not rushing out to get one, but no, joking apart, that was my fear, that you would get inundated when people weren't quite on the ball. Thank you.
Yeah.
Thanks for that, Councillor. Councillor Bowman.
Thank you, Chair. Can I ask a question about mental health? It's been reported to me that there is pressure on the mental health service, not being able to get appointments and so on. Is it because of, say, the staff levels are low because isolation, or is it because the service is under strain? And do you know the answer to that?
So there are different tiers to the mental health services. And so you might be aware that Talking Matters Northumberland is where most people would go to for their first port of call for things like counselling. And that has had extra resource put into it to try and keep on top of those waiting times. The difference in that service now is that it is all done remotely, almost exclusively. So you are much less likely to get a face-to-face assessment with somebody now, although they're using telephone and they're using video calls. The community mental health teams are the next tier up. So you can imagine somebody with a significant enduring mental health problem, and they have had to adapt. They did tend to have people on the ground, such as community psychiatric nurses, who would be going out into the field and seeing people at home. And I am aware that they are doing an awful lot more remote working as well. Now, you can see that people with mental health problems, often that can be a challenge, can't it, if you're used to seeing people face to face. I'm not aware of any huge problems with staffing, but I don't have the latest data to be able to give you complete assurance on that, so I can take that away and double check. But we do have regular situation reports from the mental health team. I think beds are always an issue in mental health services, and I am aware that they have had some COVID outbreaks in mental health services, so that would cause issues. But I also know that they've got vaccination programs and things going on as well for their patients in-house too.
Thank you for the update.
Thanks for that, Councillor. Derry, did you want to come in there?
Yes, thank you very much for the opportunity. Dr. Sayer, thank you very much for that. I've just got two issues that I really want to raise, really, from feedback that we've had at Healthwatch. About two different aspects, really. One is about the vaccination programme, and I know that I've raised this before, but we're continuing to get contact from people who are finding it difficult to travel to sites to be vaccinated. And we've had a call just today from a lady who has to travel from the west into Hexham, and she's got to have her £60 return taxi fare to do that. And she's a carer, so it's quite difficult for her. And I just wonder if there's more of a conversation that the PCNs could be having about what support could be given for people to travel to be vaccinated, because otherwise I think the danger is people are having to make really difficult choices.
That's a really good point. I mean, you'll be aware that the difficulty with the Pfizer vaccine was that we could only offer it in one place. So that was a given to start with, although the more of the Oxford vaccine, there's been a little bit more flexibility around the PCNs to be able to move some of those vaccines into sites closer to the patients. And I know the different PCNs have managed that in different ways. We can raise that with the West PCN and just double check that they are thinking along those lines when they can. I also know some of the PCNs have used need transport, I think, and looked at other options that are low cost to get people in. So we'll double check on that one as well. But you're right.
I'd be really grateful for that. And I think what the message we've been getting, because we've been telling people to go back to their surgery and raise it. And I think sometimes the surgery is going, well, we don't know what the options are. So again, I think it's that communication flow to make sure everyone's got the message. That's great. The second one is slightly a slightly different take on the mental health issues that you were talking about. And a piece of work that we've been doing at the moment is with people who have relatives in care homes. And we've just held the second forum with people in such a situation, and they are stressing how difficult the continuing stress of not being able to visit their relatives for all good reasons, which they accept. And I suppose the issue is about understanding the pressures and what can be done through the system to help the private providers make sure that safe contact can be made really with relatives, because it is starting to tell both on residents and relatives.
So it's been devastating. I have just been involved with a lady who died from non-COVID related problems in a care home, but she hadn't really seen her relatives personally for a year, and that's an incredibly common story. I think the care homes are obviously extremely anxious, because if you let relatives in to see one person and then it does lead to let's imagine the new variant is more infective. So most care homes have been super vigilant about not leaving it down to any chance at all that anybody could bring, because of having seen how devastating it is if it gets amongst your residents. All the care homes, I believe, have got access to potential digital solutions. And I think that's something that's maybe worth looking at again. And I know it's not the same. Absolutely not, but I think Wi-Fi signals in care homes, really important to make sure they're all up to date with that, and wherever possible you can get face-to-face contact. There's been some really innovative ones as well, where some care homes have set up special areas, a bit like a prison, with a perspex screen, so at least you can go and see people. But I think, unfortunately, many of our care home residents have got memory impairments, and they're never going to cope with that kind of contact. But you're right, and you're right to raise it, so we can take that forward as well.
Thank you very much.
Thanks for that, Graham. I can't see any other councillors who wish to ask any questions. So, Graham, can I thank you very much for the detailed and very informative report, and again for all the work you're doing. Many thanks from the committee and myself.
You're more than welcome, and I shall take my leave of you now, if that's okay.
You're more than welcome. Thanks, Graham.
Bye now.
Thanks now. Bye. Right, councillors, move on to item D, Northumberland care performance and impact of COVID on cancer. I believe we have Amanda Walsh is going to present this report.
Yeah, John. Yeah, Robin Hudson as well. We're doing a double act, if that's okay.
A three act. Paul McNeely as well.
Oh, great. Thank you. I was told it was only Amanda Walsh, but thanks very much. Carry on. Whoever wants to start, please just carry on.
Okay, thank you. Yeah, hi there. So my name is Robin Hudson. I'm medical director at the CCG and the GP. I gave a talk to your committee just over a year ago with Northumbria as well. So hopefully we'll be able to give you an update. So next slide, please. So overall, from a Northumberland CCG, we are graded and looked at on our overall performance, and overall our performance actually has done quite well. And in fact, there's been a slight improvement this year. Obviously, there's no room for complacency, because there are areas where there are real significant challenge, which I'll talk to later on in the slides. Next slide, please. You will recall last time I spoke to the scrutiny committee, there was quite a big pressure on urology services. And we talked at that time regarding redesign of the pathway to improve tracking of patients through the system and improve efficiency. And that work, I think, that has continued, but also it's proven to be a real benefit during the time of COVID, because I think those efficiency gains that were achieved have continued, and in fact they've started leaching out into other pathways as well. So in terms of that, giving you an example of the urology performance, it's quite plain from those graphs that the performance is very good. Next slide, please. However, there are undoubtedly some significant pressure areas. So one example would be dermatology. So as a GP, when I refer a patient in under a fast track 2-week rule, that service up till before COVID arrived, that service relied on large numbers of patients going into an outpatient department, being seen very quickly, and a decision made whether there's anything significant or not. And quite plainly with COVID, with social distancing, that's been impossible. And as a result, that has caused a significant issue with waiting times and performance on dermatology. There are some solutions, which we'll talk about in a bit later on, but that's just giving you an example of one of the challenges that the system has faced. Next slide, please. Also during COVID, the 3 major screening programs for bowel, breast and cervical, certainly detailed in the table, you'll see that early on in the pandemic, there were some difficulties that emerged, whether that be through access to practices to get cervical screening, patients just not wanting to attend, or the practices not feeling that it's safe enough, as well as breast and bowel challenges. However, screening, we know, is very important for picking up early signs of cancer, and you'll see that there has been a real effort on restoration and recovery in the last few months. And actually there have been some real benefits to the pathway from some of the innovations that have occurred through COVID. Next slide, please. So across the region, which is covered by the Northern Cancer Alliance, undoubtedly at the beginning of COVID, there was a drop-off in 2-week referrals, and Graham already alluded to the fact that there was a worry that patients just did not want to go into a practice. And if they didn't want to go into a practice, then how would we know that they needed to be referred and examined? However, 2-week referral levels have actually recovered largely across most cancer pathways, except for 2 areas which we're getting some focus on, and that's on lung cancer and head and neck cancer. I think we can speculate, I can speculate as a clinician as to why that might be, because lung cancer can be quite insidious. It can just present with a mild cough, and people may just be assuming that that's a winter cold or something. And then head and neck cancers often are just isolated neck lumps, which people maybe are not really thinking much about and are not going to see the doctors about. So further work is to be done to understand that and to improve performance. Next slide, please. And you hopefully will read this detailed slide, but basically there is a plan in terms of recovery, obviously focusing on the essential cancer treatment services, those patients already in the system, and then minimising disruption to services and getting services back to business as usual, and reducing the waits for patients. And again, some of the innovations that we've seen are actually achieving that now. So next slide, please. And it's already been alluded to, but I've been quite heavily involved in looking at how primary care can keep on track in terms of number 1, early cancer diagnosis, and number 2 on screening. And there has been continued work even during COVID regarding practices looking at their data, looking at those areas, those cancers which may be being missed, and ensuring that the services are up to speed and safety netting is occurring. Next slide, please. I'll just hand over to Amanda and to Paul.
Sorry, I'll just introduce myself. I'm Paul McNeely. I'm the General Manager for Clinical Support and Cancer Services, and I've just joined Amanda today, so we're doing a bit of a double act from this side of things. Just wanted to start with this graph really to show what's happened to our cancer referrals. And as you can see, we had a big dip at the first wave, sort of March, April time. We normally average over 1,500 referrals for 2-week waits, and these are 2-week wait suspected cancer referrals that come into the trust. As you can see as well from the graph, it very quickly got back to normal. So by June, July time, we were seeing the same figures that we saw previously. Within that, we had to adapt what we did in the trust to sort of manage the COVID pandemic in terms of making sure patients were safe coming in for their appointments. A lot of that went to virtual appointments. Diagnostics, we had to change the way we work to make sure the patient flow was safe for everybody. So we've had a lot of challenges to sort of manage this number of referrals that have still kept coming through. So for us, it's been very much like normal work from the cancer pathway. Next slide, please. And I don't want to use this slide to kind of show off or anything, but just to compare the regional performance, is the target is 85% of patients seen within 62 days. So green is good on this graph and red is bad. So we've managed to hit the performance target most months of last year, and that's been a challenge for us to do. And obviously that challenge is reflected by the fact that other trusts are struggling and haven't met the performance metrics. One other thing to mention here is that on the previous slide, there was we saw the numbers go back up to normal. There has been a slight difference in the actual tumour site one. So as Robin alluded to, lung has reduced slightly, but also breast, there's been a little bit of an increase in those numbers coming through. So although the total number is about the same, they're split slightly differently. So we're doing a bit of work to understand that further at the moment. Next slide, please. And I guess on this slide, we just wanted to show some of the improvements we have made. Urology and colorectal have always been 2 of the most challenging pathways for us. But as you can see, we've made a lot of improvements in urology pathway, and actually that over 62 days figure there, that's just a reflection of the 85% performance. So as you can see, we've reduced those people who've waited over 62 days, which is a good thing for everybody. And finally, in terms of pathways for colorectal, we've done a lot of work on the pathway and the whole team, and we're now reducing down the waiting times for those. So colonoscopy now has come down from 30 days to 21 days. We've actually allocated a lot more CT colon slots. So that's another form of diagnostic, very similar to, it just produces the same sort of images as a colonoscopy does, but it's done from a CT machine. And we've actually got a lot of provision of those. Other trusts, we've got about 200 a month, but other trusts have about 40 or 20 a month. So that's a good resource to have to help manage the pathway. And we've also made changes from the consultants and the triage up front. So they're now triaging the referrals through a lot quicker and a lot faster to help get on top of what's happening in that pathway. And I'm going to pass you over to Amanda for the next bit.
Thanks, Paul. Hi, so I'm Amanda Walsh and I'm a lead cancer nurse, and I just wanted to touch on oncology treatments, which are chemotherapy, immunotherapy and personalised treatments, because this is actually quite an important part of how we treat our patients as well. So just to say, within the trust, we've actually got 5 oncology units spread out. Our 3 main ones are at North Tyneside, Wandsbek Hospital and Hexham, and we run a small satellite service at Berwick 2 days and Alnwick 3 days. And these are all nurse-led units, and the treatments are all given by specialist trained nurses. And our consultants, we have a hub and spoke agreement with Newcastle, where our consultants will see our patients either in Newcastle or within the trust, but then all treatments are tried to be given locally as possible. And I think one of the things from the impact of COVID has been the impact on disease progression that we have seen in some patients, and also the emotional well-being of our patients undergoing treatment whilst experiencing COVID as well. Next slide, please. So this is just a graph of our oncology activity, and it's all the activity. The top green line is day cases, which include giving of treatments, line care and pre-assessments, and the bottom line is patients who attend in for what we call ward attenders, which is usually for a blood test before they have chemotherapy. The red dotted line is when we introduced new types of treatment, which you may have heard of, called immunotherapies. And these are like the personalised targeted treatments, which are now becoming very common use within cancer care. So we're moving away from standardised treatments to more personalised care, and this is the way forward. And that's had a big increase in our activity. The fact that we're treating more patients, that we're giving more lines of treatment. And for some of the treatments, they can be quite toxic as well. So it's about good care in being able to support patients as well. And again, you'll notice the drop towards the end of the chart when COVID hit in March last year. And although our oncology unit still continued to function all the way through, we did actually note a significant drop in referrals coming through as well. Some treatments were amended in line with national guidelines, and again, they've all now come back online as well. So just to give an example, maybe 3 or 4 years ago, a patient would receive maybe 4 months of chemotherapy. They now can be receiving treatment once every 3 weeks for 2 years. So it's just to show that the way we're treating cancer is considerably different as well. Next slide, please. So because we're very much aware of the impact on our patients' emotional well-being, we undertook a survey on our patients on oncology. And this was in August of last year, and we were trying to capture the views of our patients going through the first lockdown. So we managed to get 101 service users' viewpoints on their treatment and how they felt about coming into hospital. And I think in some ways we've kind of all got used to COVID and the fact of where we are, but back in March it was actually extremely scary. Everything was suddenly different and everything switched very, very quickly as well. So that's just to show the breakdown in the units. And if you go on to the next slide, please. So one of the questions we were asking about how we were communicating with our patients, because it did change. Where possible, we reduced face-to-face to telephone, not so much digital or video, because we actually found most patients didn't particularly like that. And again, we need to be mindful that not everybody has access to digital as well, but certainly the use of the phone became more common. Rather than bringing patients in to be seen, we were trying to do more checks online. One of the things we did do initially was do an initial pre-assessment using phone and or video with the family, but the nurses actually felt that didn't give good quality, so we switched back to doing face-to-face because it is quite a lot of information that we actually need to give as well. The other thing we asked was to our patients about being listened to, and 96% felt that they were actually listened to, and 98% felt that they were safe on a unit as well. And I think as a trust, we were one of the first trusts actually in the region and the country to actually test our patients for COVID and weekly test our staff as well. And the staff and patients all felt really secure in doing that. So we've just got to actually continue to do that, and that's now become standard practice. Next slide, please. This is just to give some of the comments that we've actually had back, which are actually really positive. And I think one thing that we've taken from this is that we actually need to go on and do more work in trying to capture COVID, the impact of COVID on our patients as well. And we do recognise that the support very much changed overnight, that face-to-face didn't exist, that we were very much relying on digital or phone as well, and the same for our third parties as well. Next slide, please. So just to summarise, from a trust point of view, obviously we continue to monitor all our cancer pathways, and as Paula said, we're doing some targeted work. The 28-day faster diagnosis target comes into being in April, and that's where we have to tell somebody within 28 days they either do or don't have a cancer diagnosis. I think from health awareness messages, there's been a very strong focus on trying to encourage patients to come in to hospital, to go to the GP if they feel something is wrong, and then come into hospital as well. And I think, again, that's changed from the first wave. We have received some funding from the Northern Cancer Alliance in regards to COVID recovery and what we call rapid diagnostic pathways, which is our next piece of big work. The other thing as well is our patients, the majority of our patients fall into highly clinical vulnerable group, which is category 4, which are due or just starting to go through to be vaccinated now. And again, we've got national guidelines on regards to that as well. And the other thing just to mention about community diagnostic hubs, which again, there's some work going on regionally and nationally about providing more diagnostics and how that might look within the region. Robin, I'll hand back to you.
Yeah, so thank you, Amanda. Just to say that the CCG and the Trust and myself and Amanda and our team, we work so very closely together. We're in two-way contact on a regular basis, whether it be issues being observed about general practice or vice versa. So just to assure the committee. In terms of the developments over the last 12 months, just final few slides. I think with COVID, people say that in times of war, that's the time when the greatest innovation can occur. And I think probably that analogy works with this time of war against a virus in terms of accelerating change, stuff that was due to happen, and it's just accelerated the pace of change. So for instance, colorectal, we didn't really have the tools available to work out if a patient sitting in front of me in my practice had cancer. We had to refer them into Northumbria, and Northumbria didn't. The only tool they had was a colonoscopy, and the numbers of colonoscopies that were taking place to yield very few cancers was huge. And that's changed now with something called the FIT test, which is a new test which GPs can do, which actually allows our consultant colleagues to look at these referrals being made, and actually they're able to better focus colonoscopies toward the highest risk patients, and lower risk patients have a CT scan. The result of that has been a massive impact on waiting times for the benefit of patients. And I think that has to be commended. And that wasn't just Northumberland, that was region wide, but the change was excellent. Another innovation is digital dermatology. So again, this is a regional innovation. I talked to you about the large numbers of patients who used to go to the melanoma clinic at the RVI, which can no longer occur because of social distancing. All practices now have an iPhone with a dermoscope attachment, which allows them to take 3 photographs of a skin lesion and to email that to the RVI. And that's allowing dermatologists to say, no, that's not a suspicious lesion, or yes, that is, we need to see the patient. And that's having a massive impact again on, well, it will have a massive impact on terms of waiting times and who needs to be seen down in Newcastle. And then other innovations, we've got the Northumberland, North Tyneside, Newcastle Gateshead CCGs are meeting with Northumbria and Newcastle to discuss cancer and closer working together, which has been great. It's really well supported, and we're making real inroads into cancer through that route. Our networks are doing an amazing work on early cancer diagnosis. We've run 3 GP education sessions in the last 3 months. 1 on neurology, 1 on colorectal, and 1 on head and neck cancer. That's been for our practices and done remotely over lunch, which actually proved to be very effective and good engagement. And just change the next slide, please. And last but not least, it's about this community engagement, community cancer awareness, which is really important. And that work has continued. However, a lot of it's had to be done remotely and online, which is not our desired way, but it is the way that we've got at the moment. And a whole number of different campaigns have been occurring, and education campaigns. So that's just to reiterate its importance. Next slide, please. And then final slide, I promise. Number 1 is something called personalised care, and this isn't to be confused with what Amanda was talking about in terms of specific cancer treatments. is actually the next step we have to do as a system is looking at patients who have been discharged from treatment. We know from national surveys that a lot of patients feel forgotten. They feel as if they drop off a cliff and nobody's interested anymore. And there are enduring challenges which these individuals have, not just with having had a cancer diagnosis and treatment, but the implications in terms of finance, emotional well-being, employment, marriage issues, all these broader things to do with life and moving on in life. And we really want to start moving into new territory in terms of improving the support of those individuals, improving the offer to those individuals 3 months, 6 months, 12 months down the line when they may be still struggling with some of these issues. And then the final point is about we're looking at how to join up our diagnostic pathways to a greater extent. So rather than just looking at somebody with a lower bowel problem, thinking about it in its entirety and how better to work between primary and secondary care to improve that patient journey. Last slide. Thank you.
Thank you for that. I think all of us probably know somebody who's got some form of cancer and awfully worried about whether the COVID would interfere or how it would affect the treatment. Right, councillors, any questions to either Robin, Amanda or Paul? I have Councillor Bowman first.
Thank you, Chair. I am a cancer survivor. Thank you very much for the work that you have done in the NHS to save my life. It was amazing. But I do have a few issues with these difficult times, because I recognise my treatment was hands-on, as it were. It was physical. It was the treatment that I received, the diagnostics, was about it was a physical person dealing with me. So in these difficult times, are we 100% sure that we are actually catching every diagnostic and making sure that everybody is safe and that every test is 100% sure? Can we have some assurance in these difficult days?
Yeah, I mean, if I'm happy to come in on that one, there's a very good point. I think what we've had to do is adapt to what we've done, but to get a cancer diagnosis, a lot of people have to physically come in for an examination, have to come in for a scan, have to come in for a scope, have to physically attend. It's very difficult to make a virtual cancer diagnosis as such. So from that side of things, yes, it's been about how we've adapted our environments to make them safe for patients. A few things to give examples is if patients go on to have surgery, we have to factor in them getting COVID swabbed in 3 days before they have their surgery so that they're negative, and we know that they're safe from COVID before having the surgery, because we know COVID can cause complications with surgery. So I'd like to give you that reassurance that it's that the initial appointment may well be virtual with a consultant, but then the diagnostic pathway is very much as it always has been, because it just relies heavily on physical scans, physical tests where patients have to come in and be attended. So I'd like to think we are still have that same level of assurance as patients go through the pathway.
Thank you. Councillor Bowman, did you want to come back, or are you happy with that reply?
I'm really happy with that. I was concerned, and like I said before, thank you very much. I've got nothing but praise for the NHS. And my doctor, though he was bad-tempered, he actually saved my life.
Don't have everything, Liz. I can't see any other councillors with their hands up. So Robin, Amanda and Paul, can I thank you all for the excellent report, and again for all the unbelievable work that you're doing. Thanks from all the committee and all the residents of Northumberland. Thank you.
You're welcome. Thank you.
Thank you.
Right, councillors, agenda item 7, number E, or letter E, the work programme. I think we're just about through the work programme. I think end of life and urgent care. Chris, did you want to say anything on that?
Not particularly. I think to raise on the work programme, obviously we're coming towards the end of this sort of council year. So if there's anything members want to have included on the work programme, there's very limited time now. Next month we've got an update coming from the Coroner's Service on some of the changes they're going through and the work they've done throughout COVID. And we'll also be getting a further sort of vaccination COVID update from Liz Morgan and the CCG. In April, we'll get the quality accounts from Northumbria and CNTW. So there is a little bit of room on there for some stuff to be added to the work programme if members want. But just to be mindful that we are getting towards the end of the council year to factor things in. But that's all I wanted to say, Chair.
Thanks very much for that, Chris. So if any councillors, as Chris says, either contact me or contact Chris if they have any matters that you'd like to bring onto the work programme. Urgent business, I don't have any. I can't see any councillors indicating that they want to speak. Thank you all for a really good meeting and some very good reports and showing the fantastic work that's being done in not just this area but in the country, but especially very proud of this area. The date of the next meeting is Tuesday the 2nd of March. Can I thank you all for attending, and we'll see you there, and please take care. Thank you all.
Thank you, Chair.